So I would come in and introduce myself to the patient, wash my hands, make sure I have my 5 rights, check the patient, the dosage, and all those things. Explain to Jane here after I checked her band that I'm going to be giving her a heparin today and let her know the side effects, especially of bruising and things like that. I would do all the patient teaching beforehand before I even administer the medication so that they're aware of the side effects that may happen. I would wash my hands, do all my calculations, which I just did. The heparin, I'm going to do the loading dose of 75 units per kilogram bolus, which ends up being 0.8 milliliters of the 5,000 units per mil concentration. So I'm going to dilute that. You don't have to, but I'm going to because you want to give the first 1,000 units over 1 minute, and then the additional can be up to 5,000 over 1 minute after that. So I want to make sure that I'm not pushing it too fast, because in the 0.8 milliliters there's 3,750 units of heparin. So I'm going to mix it with the normal saline. I'm not going to put the saline and pull back. I'm going to put the heparin into the saline, and then I will probably twist it a couple times, make sure it's well mixed so that it's not going to do anything. So I would administer the bolus dose. I'd scrub the hub on the patient and then administer it over 1 minute first. I would only give the first, let's see, I wouldn't want to give more than 1 mil, so I'd probably give, of the diluted, I would give 2 milliliters of it over the first minute, and then I could slowly do the rest over the next minute. Then I would have to also have my math ready for my heparin drip that I'm going to set, and I'm going to run it with D5W, and we're going to run it concurrently. So the D5W, this wouldn't be 2 sets like this. It would be a set of the D5W, and then I would run a concurrent line of the heparin, so that if we run the heparin that slow, it would probably clog up the line. It might not go through too, and plus the D5W is ordered. So we're going to set the D5W at 25 mils per hour, and then we're going to run the heparin concurrently at 20 mils per hour. And then it says to titrate per protocol. So obviously we're going to take blood levels and count the CBC and things like that and keep track of their platelet level. I would also do hand hygiene again after I leave the room. I would have gloves on when I'm doing the IV things, obviously, just in case there's any blood return somewhere. And I would have the antidote on hand, which is protamine sulfate, just in case something happened. Like excessive bleeding, some hemorrhage, really just some thrombocytopenia and things like that. And that would be it. Thank you. So now I have the lidocaine patient, and at Smith, I would do all the same checks again, wash my hands, do the 5 rights for the patient, check the label, make sure I have the right patient, things like that, explain the side effects and that they can expect. In this situation, I might not explain them right away because the fact that the person is having PVCs, so we're probably just going to give this medication because it's an emergency situation. I did all the math, and the bolus of 0.7 milligrams per kilogram ends up being 89 milligrams. With the 100 milligram per 5 milliliter solution, it'd be 4.4 milliliters. And we only want to give 25 to 50 milligrams over 1 minute, and we're giving 89 milligrams. So we're going to go ahead and give this over 2 minutes. We do not need to dilute it. We do not need to dilute it. We can if we want. This is 4.4 over 2 minutes. I think I can handle that, and it's in a 5 milliliter syringe, so it'd be perfect. We're going to give this medication via the middle port on the subclavian. The longest port, the distal, is already running her fluids. We're going to leave the proximal for blood if they need anything. So I'd go ahead, scrub the hub, administer this over 2 minutes, and then we would go on to the drip rate, which we're going to be doing a drip of 2 milligrams per minute, which is actually 120 milligrams per hour. And you either need to do micro drip tubing with this lidocaine or go ahead and run it with a pump. And we can run this concurrently with the normal saline. I believe we double check. But we should never exceed 200 to 300 milligrams per hour with this medication. Actually says compatible with normal saline. So we can go ahead and run this concurrently. We'd add it in here, set the pump for 120 milligrams per hour. We're going to do the patient teaching afterwards. When the patient's feeling better, we're going to let them know the medications we gave them, the side effects, things like that. I'm going to do my hand cures before and after all this procedure, wear gloves with the IV, especially since this is a triple lumen room. Be super careful because it's a central line. We don't want to induce any bacteria. And that would be the lidocaine. So this is the Dilaudid patient, and they already have TPN flowing in the medial line, and they have D5 1/2 normal saline in the distal line, and the proximal line is left for blood. So what we want to do is administer the additional 1 milligram of Dilaudid that this person can still have in the next 3 hours because their pain is obviously intolerable at a 9 out of 10. So they've already received 0.5 and they can get 1.5 per 3 hours, so we're going to give the 1. I would explain all these things to the patient. I would have already explained the side effects and things like that with the first dose, and I would remind them of them and see if they know them. I would perform handling coming into the room, introduce myself, do the 5 patient rights, check allergies, which are morphine and eggs. I would also make sure that these lines are still running and everything's okay, reassess their pain, and make sure that everything is ready. I would do all my math, which I have. The 1 milligram equals 1 milliliter because that's what we're using of Dilaudid. And what we need to do, since it is a central line, is we have to do SASH, which is saline, administer saline, and then heparinize. And what we wrote down before was that we always want to use 2.5 to 3 milliliters of heparin. So I do have the 3 milliliters of heparin drawn up. So what we're going to do is, I was looking up, and you never really want to use less than a 10 milliliter syringe because otherwise it's going to cause too much pressure on the line. So I do have a saline flush here, and then I used another saline flush. I got rid of 5 mils of it and then added the 1 mil of Dilaudid. So it is 6 milliliters in here, and we're going to be giving that over 2 to 3 minutes. We're just going to do 3 to be safe. And then we're going to go ahead and do the second flush. And then I have the 3 milliliters of heparin, which are going to heparinize the line. So I would do all that. Obviously, I'd scrub the hub and administer these one after the other. These would all have caps on them. They'd be fresh. And then I'd also reassess the patient afterwards. If they have any side effects, Narcan is the antidote. We just need to make sure that we have oxygen on hand. We keep reassessing the vitals, their pain level, inform them that they need to ask for help if they're going to get up, start them on laxatives if they're going to be on this pain medication for a while because it's definitely going to cause some constipation. Like I said, I would perform hand hygiene when I came into the room, before the medication administration, and afterwards, and when I leave the room. And that, oh, I didn't say, we're going to administer the medication through the line that the D5 1/2 normal saline is running. We don't really want to put anything in the bloodline if we don't have to. And this line is compatible, so we're just going to go ahead and run it through there with that. And that is why we're going to flush and things like that in between. It's not compatible, like I said. We're going to, not compatible, sorry. We're going to do the flush and things like that. That's why we're going to run it through that line that way. And that's it. Thank you. So this is the insulin patient. In all other scenarios, just the same. I would perform hand hygiene upon coming into the room, introduce myself, check the patient's band, make sure I have the right patient, right room number, all the patient rights. I'd explain the insulin medication to this patient. Obviously his blood sugar is 560, which is incredibly high, and he's been diabetic since he was 7, and he has taken his insulin today. So the insulin order is 8 units IV bolus stat. So we're going to drop 8 units of insulin in a insulin syringe, because obviously you can't measure the units in a milliliter syringe. And then we're going to add it to some normal saline so that we can administer it over 1 to 2 minutes, because it's obviously easier to give 5 milliliters of saline plus the insulin over 2 to 3 minutes than it is to give just those units, plus the fact that you cannot use an insulin syringe directly into an IV. So we diluted it, we're going to administer over 2 to 3 minutes, and then we also have to do the IV infusion, which is going to be running at 8 milliliters per hour. Because it's 250 units per 250 mils, but we can't run something that slow at 8 mils per hour. So we're going to hang a second bag, which I don't have here, but there'd be a bag of saline, and we're going to run that at about 25 to 35 milliliters per hour through the pump. And then we would add the insulin in on the hub and run that concurrently at the 8 mils per hour. If we weren't able to do concurrently, we could run it on 2 pumps. Because we'd obviously want to make sure that insulin isn't going any faster than it is. We need to do patient education on hypo and hyperglycemia, and then we need to also have glucagon on hand. Like I said, there's hand hygiene when I come in the room, before I administer the medication. I'd also wear gloves for setting up the IV and things like that. And we do hand hygiene afterwards again. And that would be for this patient. This is the Rapamil patient. With any other patient, when I enter the room and perform hand hygiene, introduce myself to the patient. This patient is 82 years old and experiencing some tachycardia and things, so the patient teaching might not be the same as it normally would because he's in some severe distress. So I would make sure I know everything about my medication too, and if the patient education doesn't happen before, it would definitely happen after. We would let him know everything that happened. We want to give this patient 5 milligrams IV now. So the 5 milligrams would be 2 milliliters of the 2.5 per milliliter solution of Rapamil. And normally you would push that over 2 minutes in an adult, but you kind of want to go with 3 minutes with the elderly, is what it states. So I think I would dilute it, because it's kind of hard to push 2 mils over 3 minutes. So I would dilute it with normal saline because it is compatible. And the D5NS is running, so we're just going to go ahead and give this at the Y site. Like I said, we're going to administer this over 3 minutes. Obviously, perform hand hygiene again, scrub the hub before I administer, things like that. This medication has many different antidotes based on the reaction that occurs, so we'd make sure we have all that information in those medications and devices available on hand. Just inform the patient of the side effects that might happen. And then with this medication, like it said, it does need to be repeated in 30 minutes if no response. The maximum is 20 milligrams, so we can only repeat this 4 times without having results, and then obviously we need to go somewhere else from there. And that's it. Thanks.